Welcome to Progenesis Academy webinar. For those who are not familiar with our program, we are a nonprofit program dedicated to embryology, reproductive genetics, and endocrinology education. Today, we are having a very good topic, IVF success. So the title is IVF Success, Essential Factors for Optimal Outcome. We have invited a very good speaker today. We are very fortunate to have Dr. Roseff, fertility specialist from IVF MD. Dr. Roseff, thank you so much for joining us.
Thank you for having me. Appreciate it. So I've been practicing for 33 years and have been doing in vitro fertilization for all of those 33 years. And it's been incredible how our success rates and our techniques have changed and improved over the 3+ decades that I've been doing this. I see several new patients every day, and the heartbreak that I see, the problems that I see tend to be due to patients who have gone through IVF elsewhere. I see a lot of patients who previously failed IVF for one reason or another, and when I review their medical records and go through everything that they've been through with a fine-tooth comb, I realize that many of those patients, if we looked at certain factors in them before they did IVF, it would be predictable that the IVF would likely have failed. And my heartbreak every day, I feel terrible for people who go through the physical and emotional and financial devastation of one or more IVF cycles. And every day I hear from patients who I see, new patients, I wish I came here first. Or I may say to them, I really wish you were here 2-3 years ago, because it would have been a very different journey. Having done this for so long and being a board certified expert in reproductive medicine and of course in vitro fertilization, I know what the factors tend to be that can lead to success or failure of the IVF cycle. And so I thought it would be very important when Progenesis asked me to give a talk, a webinar, I thought, why not share with you what some of those essential factors are for optimal outcome. This way, if you are contemplating IVF, if you end up doing IVF, or if you've been through IVF and failed and perhaps wonder why, I hope that if you learn one tidbit from some of these factors that I've put together for optimal outcome, if somebody is helped from this, then I think this was a positive presentation. So many people come to me and say, or the doctors even say, IVF is get the egg, get the sperm, fertilize the egg, make an embryo, and put the embryo into the uterus. In vitro fertilization is not simply a matter of get the egg, get the sperm, make the embryo, transfer the embryo to the uterus and cross your fingers. There are so many factors in both the men and in the women that can lead to success or failure of an IVF cycle, and it's important to know what they are, and we're going to discuss some of those tonight. One of the essential factors is choosing the right IVF clinic. Sometimes it's really hard to know where to go. Now, in the days of virtual consultations, I'm seeing patients from all over the United States and from other countries. And so if I have a patient in Wisconsin who wants to go through in vitro fertilization with me, we can do all the consultations online virtually. And then the patients sometimes can do testing locally, or they can come to my center, IVF MD in Florida, and spend a short period of time, get some testing done, go back home, and then we can put together the plan. So it's just because an excellent IVF center is not local, doesn't necessarily mean that you can go to a distant IVF center and have perhaps better success than you would locally. The argument against that is when people say, I have to fly and pay for the flight, I have to take time off, I have to stay at an Airbnb or a motel or a hotel. But yes, there's cost to that. But on the flip side, if someone stays locally at a center where it's not optimal for outcome, then there is a cost at the other end of that may be the same or even a greater cost of failure. So it's important to choose the right clinic. One of the ways to find an IVF clinic is to read the online reviews. There are different websites where people review the IVF clinics, and they're often helpful, but you have to be careful because there are companies that the doctor or the center can pay. One of them that I was solicited for was called reputation.com, where for a monthly fee, the reputation business will actually write positive reviews. They say, we can get your negative reviews off the website. We're just going to load it with positive reviews. So you have to be careful when you read reviews, because sometimes those might be paid reviews. How do you know? It's difficult to know if it's a paid review, but one of the little tips or one of the little facts is that if you read the review and it's a little bit generic, it's a little bit general, oh, I went to the doctor or that clinic and it was a great experience, it was wonderful. There's nothing specific there. It's not mentioning the doctor or doctors, it's not mentioning the nurse, it's not mentioning the assistants. There's nothing specific there. So if it's general, oh, I had a wonderful experience, then you have to be careful with that. There are social media pages that have IVF support groups, and I've seen many of them on Facebook, IVF moms, IVF patients, low ovarian reserve groups. There are these different fertility support groups that are on social media like Facebook, and sometimes they're very helpful. But you have to be careful, because if someone says, well, I did this treatment and it worked, it doesn't necessarily mean that you have to go to your IVF doctor or your IVF center and say, that's the treatment we need to do for success, because what worked for her might not be appropriate or right for you. Most IVF centers have a website where you can click on a link and read success rates for in vitro fertilization. Those links typically go to the Society for Assisted Reproductive Technologies, or SART for short. And those reports are confusing, they're cumbersome, they're often difficult to interpret, but it's better than nothing. And so sometimes it's important to look at the success rates for SART. If the IVF clinic says, here's our success rates, you have to be a little bit cautious with that, because that may or may not be correct. It may not be accurate. I've seen websites that say our success rate in 2016 was so-and-so. Well, that's old data, it's old information, it's not up to date. Another thing that you may want to consider, it's not critical, but certain doctors have achieved what we call board certification. Board certification is often considered to be the highest level of expertise that we can achieve in the field. And if a doctor is not board certified in the fertility field, sometimes, not always, that's a little bit of a red flag. And the other thing that I think is really important, I mentioned that I have 33 years of experience in the IVF field, and the number of years of experience can really be important, because I've seen everything, I've done everything, I've come across everything and anything that can possibly happen, whereas doctors who are in the field but for less number of years may not have that level of experience. Now, I will caution you, there's a doctor who does IVF not far from where I am, and the doctor has been doing it for longer than I have. But if the doctor is not at the cutting edge of what's happening now and practicing older techniques, then the success rate may be lower, the experience may be poorer. So just because somebody's doing it for 35 years, if they're not at the cutting edge of reproductive medicine, it doesn't necessarily mean that 35 years is the place to go. So that's important as well. A lot of people come to me and they say, well, I guess we're going to have to do this several times, this IVF. I was in a support group recently where I headed up a support group, and we sat in a circle, and one person in the circle said, yeah, anybody who does IVF will have to do it at least 3 times. Somebody else in the support group said, yeah, I agree, maybe 3, maybe 4, maybe 5. And I asked them, I said, what do you mean that you have to do this 3 times? Why couldn't you do this once and make it the best it can be? So a lot of people expect that, but that's not necessarily true. They say that their friends had to do it multiple times. So if my friend had to go through 2, 3, 4 IVF attempts, then I guess if I go there, I'm going to have to do it 4 times also. Not necessarily true. A lot of patients say to me that when they went to the other IVF doctor or other IVF clinic where they failed, their doctor literally told them, well, we're going to do IVF, and if it doesn't go well, then we'll look at why it didn't go well. We'll figure that out, and then we'll see if we can make it better the next time. We don't want a next time. We want to do it right and best the first time. Let's not wait for failure and then figure out what the problems were. Some patients go on these support groups and support blogs and read online that other people are just going through this over and over and over. I see patients who come to me as new patients having failed 7 IVF cycles at other centers, and that is very upsetting to me. Some people just Google search IVF, how many attempts? And again, it doesn't mean that you really have to do this more than once. If you do it once and make it right, then it should work. My motto has always been, and especially for in vitro fertilization, you want to do this once, you want to do it right, and you want to just make it work. When I sign off on my social media pages, that's my hashtag. Do it once, do it right, make it work. So the way that I do things a little bit different is I want to optimize everything with my patients before they do IVF, so that when you do IVF, it's most likely to be successful the first time and the only time that you do it. You don't want to wait for IVF to fail and then look at the reasons that it failed and say, we could have done this and we should have done that, and maybe we could have done that, and why didn't we do that? Don't want to do that. Too many people ignore lifestyle choices. Lifestyle is the way you live and the things that you do. And I get records from so many patients who have failed IVF elsewhere, and they're smoking cigarettes, and the doctor says, oh, you should stop. But then 3 weeks later, they're starting in vitro fertilization. They discuss at the first consult, don't smoke cigarettes, that's bad. And then when you get your next period, we're going to start IVF. They don't ask the patients if they in fact did stop smoking cigarettes. If they did stop, those thousands of chemicals from the cigarette smoke are still in the body 3 weeks later or 4 weeks later. You have to give it time for it to get out of the body. So cigarettes are a significant factor for both men and women. No cigarette smoking. There are few people who smoke cigars. A lot of people. Smoking anything can have a negative impact on IVF success. No cigars. Then the male partners say to me, I only have 1 cigar every 2 months. 0. If you're going to do IVF, no smoking cigarettes, no cigars, no vaping nicotine. Alcohol. I had a patient recently who failed IVF elsewhere, and I said, do you drink alcohol? Her answer was, oh yeah. And I said, well, what's oh yeah? And she said, a lot. And I said, well, a lot to you, maybe not a lot to me or someone else. So I said, what's a lot? And she said, well, I have 100 glasses of alcohol a week. And I don't judge people, and I'm doing what I'm doing to help people have IVF success. So rather than tell her she needs to go to rehab, and I told her that once you go above 3 drinks or 4 drinks a week, then your outcome can suffer. So you have to limit alcohol. 0 is best, but it's not a perfect world, and a few drinks a week would likely be okay. In Florida, where I practice, it's legal to obtain with prescription medical marijuana. In many other states, medical marijuana is legal, and in some states, recreational marijuana is legal. Marijuana, vaping, smoking, edible, appears to have a very negative impact on IVF outcome. I get a lot of medical records of patients who failed IVF elsewhere, and when I look at the history the doctor took, are you smoking pot? Are you using marijuana? Yes. Next question. There's no discussion about stopping. And I don't say to stop to make people miserable. I say that marijuana, smoking, vaping, and edible can have a very significant impact on IVF outcome. So 0. How long do we wait once we stop? About 3 months to detox it. Another lifestyle issue is exercise. A lot of people don't exercise. So there's too little exercise in general. And actually, too much exercise can have a negative impact as well. It's really hard to define what's too much exercise. I'm not anti-exercise. I'm very pro-exercise and pro-health, but too much exercise is not in someone's best interest if they're trying, the female trying for IVF success. And we do have that discussion. I used to talk about the effect of weight on IVF outcome, how much you weigh. But weight is a relative term. I have women who are literally 6'2" and let's say 200 pounds, and that's okay. But I literally have women who are 4'2" and they weigh the same thing, 200 pounds. That's not okay. So we take your height and we take your weight and we calculate a body mass index, BMI. And the BMI categories are underweight, normal weight, overweight, obese, and morbid obesity. And if someone is an underweight BMI, we have a device in my office in Boca Raton where we actually measure body fat. And there are normal weight people and certainly underweight people who have low body fat. And we're going to talk in a minute about body fat. Overweight BMI is usually higher body fat, and my obese patients usually have high body fat. And body fat, we used to think just sat there. We had a little body fat or a lot of body fat or somewhere in the middle, but we now know that body fat is like a factory and it produces things. And one of the things that body fat produces is estrogen, female hormone. The more body fat we have, the more estrogen we tend to make in our fat, and it goes into the blood, and that has a negative impact on IVF success. And also, if we have too little body fat, then we don't have enough estrogen in the body, and a sufficient amount of estrogen is critically important. A man who has a lot of body fat has a lot of estrogen, and estrogen counterbalances testosterone. If there's too much estrogen from a man's body fat, his testosterone levels tend to be low testosterone, poor sperm. So body fat is really important. The other thing that's critical that a lot of people don't know about body fat is that that factory produces something called cytokine. And cytokine causes inflammation. The more body fat we have, the more inflammation that we tend to have. And high inflammation has a negative impact on sperm and eggs and embryos and all kinds of things like that. So that's really important. There's a saying that I'm sure everyone has heard, you are what you eat. And when it comes to IVF, it's true. If a man has bad nutrition, then we get bad, or what I call sick, sperm. If a lady has bad nutrition, then we get bad or sick eggs. If you put sick sperm and sick eggs together, we end up with sick embryos. And when we have unhealthy embryos, as they're growing in our IVF laboratory, they tend to start fragmenting, they tend to start falling apart. If the embryo is not in good health, then it stops growing, it arrests its growth, it dies in the laboratory. How many times we've heard, oh, we fertilized 10 eggs, and then 5 days later, all the embryos stopped growing. That absolutely positively could be due to poor nutrition in the man or the woman, resulting in poorly nourished embryos. And then if they don't die and we have embryos in our laboratory, if they started out with not great sperm due to poor nutrients or not great eggs or both, we take those embryos and put them in a uterus, and they often don't implant. If they implant and they're not in good health, they miscarry. So lifestyle choices matter, and that's something that I focus on in my IVF practice, and it's critically important and often overlooked. I saw a patient recently who went through in vitro at another center, and they didn't measure her body mass index, but she was 500 pounds. And not to point fingers and not to be judgmental, but 500 pounds going through in vitro is not going to end up well. And when her IVF failed the first time, her doctor said, it didn't go well, so I guess you're going to need to do that again and again. And if I had seen that in the beginning, I would say, we're going to work on that before you do IVF, not put someone through repeated failed cycles of IVF. I'm very big on supplements. I'm known for supplements. I've done research on supplements. I've published papers in peer-reviewed medical journals on fertility supplements. I've been flown to other countries to give lectures on supplements. I recently co-authored a chapter in a textbook on supplements that I use in my fertility practice. Supplements can be very helpful, but they can also be bad. I saw a patient yesterday, a new patient, who was taking dandelion extract for her eggs, egg improvement. And I said, where did you get dandelion from? And she said, well, I Googled it and I found that it was some Google website said it was good. Dr. Google could be wrong. So you have to be really careful with doing your homework on supplements. In the United States, there's no control or oversight whatsoever on the manufacturing quality of over-the-counter supplements. So you can make vitamin D at home. You can put a label on it, say it has 2,000 units of vitamin D. You can sell it at Walgreens or CVS, and unless somebody independently checks what's in it, it could have nothing in it. And sometimes we get bulletins from the Food and Drug Administration, the government, where they did find out that certain supplements had problems. Example, we got a bulletin from the FDA where they found that 13 different brands of a popular supplement a lot of my patients come to me taking were found to be contaminated with lead. And lead is one of the most toxic things on the planet for the developing brain of a baby. And so you have to be really, really careful with the brand and where you're buying it from. And so you have to be careful with taking supplements. The quantity matters too. If you're taking too little, it's not going to do anything. If you take too much, more doesn't necessarily mean better. And certain supplements can actually cause problems if you take too much of them. So I would suggest that you do ask your IVF doctor, your reproductive endocrinologist, for recommendations on supplements. If they tell you to just Google it, or do your own homework, or do your own research, or figure it out, that would concern me. A lot of patients do fertility acupuncture, and the acupuncture fertility experts often know what some of the better supplements are. So if your doctor can't help you or doesn't help you, that would be something to consider. I do a lot of tests on my patients. I don't get paid more money to do the tests. It makes my day longer to go over the results. It makes my day harder. I don't have investments in the labs where these tests are done. There's nothing in it for me, but we need to do tests and more tests on both the male and female partner before we do IVF. Now, one of the tests that I do on both partners is not a fertility test. It screens their blood for hundreds of genetic diseases that can cause a baby to be born sick or a baby to die. Example, there is a genetic disease called Tay-Sachs. If both the male and female partners carry the gene for Tay-Sachs, every embryo, every baby has a 25% chance of being born with Tay-Sachs genetic disease. A baby born with Tay-Sachs will die by the age of 3. I saw a couple who had failed multiple IVF cycles elsewhere about a month ago. Their doctor screened them for 3 genetic diseases, and they were not a carrier of any of those. In my practice, we screen for almost 300 genetic diseases. And when I screened this couple for the expanded screening that we do, indeed, they were both carriers of a very serious genetic disease that simply was not done at their prior fertility clinic with their fertility doctor. So even though it's not a fertility test, in a perfect world, everyone goes through universal genetic screening to make sure that we don't have genetic diseases that are going to cause a baby to be sick or die. And if both partners do carry that genetic disease, then we can test the embryos for the disease, eliminate the one that has it, transfer the one that does not. For the male partner, basically everybody gets a semen analysis, and a sperm analysis looks at the sperm on the outside. We count it, we look at how it's swimming, we look at how the sperm is shaped. That's important, but at the end of the day, it's DNA of the sperm that combines with DNA of the egg to fertilize the egg and make an embryo and a pregnancy. It's DNA at the end of the day that's most important. I check not only a sperm analysis, but I check the fragmentation, the breakage of the DNA in the sperm. The laboratory also looks at the functioning, it's called decondensation, of the sperm DNA. How is it working with the egg DNA in a laboratory test setting? It's not a very expensive test, and it's critically important because if you do in vitro fertilization without knowing if the sperm DNA is fragmented, broken, for example, and you take that sperm and you put it in a needle and you inject the sperm with the fragmented DNA into the egg, the perfect egg, then half of the embryo comes from the sperm DNA and half comes from the egg DNA, and half the embryo will result from fragmented DNA in the sperm. Those embryos are more likely to stop growing in the laboratory. They're less likely to implant when we put them in a uterus. They're more likely to miscarry. And so it's really important, most important, when we're checking sperm, to actually check the DNA on the inside rather than just look at it on the outside. Anybody who goes through in vitro fertilization, female, will typically check what we call ovarian reserve around the 3rd day of the menstrual cycle, menstrual period. We check hormones in the blood, FSH, follicle stimulating hormone, estradiol, anti-Mullerian hormone. And we also do an ultrasound at the same time to count how many eggs, how many follicles are growing. I see patients who fail IVF elsewhere and their follicle count there was 3, and their AMH, and the 3 is poor, by the way. It should be 10 to 20, depending on age. And the AMH, the egg test, is 0.3. That's horrible. Their doctor didn't tell them what that meant. The doctor didn't go over the ramifications of it. The doctor didn't talk about supplements and fertility acupuncture to try to improve that. So the doctor took them through in vitro. They retrieved 2 eggs. One of those 2 eggs was not good. The one that was injected with the sperm arrested its development. So ovarian reserves is one of the tests that you need to do, but discuss the results with your doctor. What does it mean? What does it show? What are the ramifications? It helps to predict your outcome for IVF. If it's not good, what can we do to possibly make it better? There's a hormone called prolactin that I also check at the same time. I see people who come from other IVF centers where the doctor didn't check prolactin. If the prolactin is not normal, it lowers the chance of pregnancy and dramatically increases the risk of miscarriage. Thyroid stimulating hormone, TSH, super important. Thyroid is important for health, but it's also important for IVF outcome. When the blood test is done for TSH, thyroid stimulating hormone, and it goes to a commercial laboratory, and you look at the normal range, 0.4 to 4 point something in that laboratory, and the patient, the female's test came out at 3.9, which is in the normal range for the laboratory. In reproductive terms, that's not good. The cutoff, the normal range, is strict. If you're trying to get pregnant, wanting to be pregnant, attempting to be pregnant, are pregnant, the cutoff for TSH is much different than for health purposes. And if the thyroid stimulating hormone level is off by 1/10 of a point, it can double the risk of miscarriage. So keep a close watch on the TSH. I do a blood test that looks at how, it's a genetic test that looks at how the body absorbs and processes folic acid. Folic acid is a vitamin B derivative. Folic acid is important for development of a baby's brain and a baby's spine. Folic acid lowers miscarriage risk, and there's some evidence to suggest that folic acid can lower the risk of autism in babies. And there's a gene, like our genes control our hair color and eye color and beating of your heart. There's a gene that controls the processing and absorption of folic acid. It's, the name of it is long. It's a methylene tetrahydrofolate reductase gene, or an MTHFR gene. I do that test on my patients because if it's not normal, we need to treat it above and beyond the standard typical prenatal vitamins that I prescribe. There are antibodies against the thyroid. I don't want to get too technical, but there are 2 types of antibodies in the blood that we check in the female. One is called TPO. And I get a lot of records from other IVF failures where the doctor checked the TPO antibody. That's good, but it's not enough because there's another thyroid antibody. It's the thyroglobulin antibody. And if these antibodies are not normal, they predispose to IVF failure. And a lot of thyroid associations are now recommending low dose thyroid medication for IVF patients if their thyroid antibodies are positive. So if your doctor only looked at your TPO, your peroxidase antibody, it's not enough. Make sure the other one's been looked at. I look at lipids, cholesterol, triglycerides, your HDL, your LDL, the fats in your blood. We've known forever that cholesterol is related to cardiovascular disease, heart health, but there are papers now published showing high cholesterol lowers the chance of IVF success. So we look at fasting lipids. CBC, ferritin, iron, total iron binding capacity, those have to do with anemia. Anemia has to do with the oxygen carrying capacity of your blood. If you're anemic, then you have difficulty carrying oxygen through your body. If you don't oxygenate your pregnancy, those pregnancies tend to have problems. And so it's important to look at that. I screen every patient for toxins like lead, because there's lead in the water supply in certain places, arsenic, which sometimes we find in apples and apple juice and rice, and mercury, which is most commonly found in fish. Most people eat some fish. Most fish have mercury, some way more than others, like swordfish. There, about 2 weeks ago, I had no less than 5 patients in a week with high mercury in the blood. Mercury high in the blood circulates to the sperm. High mercury in the sperm results in high mercury in the embryo. High mercury in the eggs goes to the embryo. High mercury in an embryo can damage potentially a baby's brain. There's also now evidence to suggest that mercury, if it's high in the blood, has a negative impact on the uterus, which lowers embryo implantation and increases miscarriage. So I check lead, arsenic, and mercury, really important in my opinion. I measure, especially in my female patients, markers of inflammation, really important. Inflammation is a big buzzword in the medical field now. If we have high inflammation, irritation in the blood, it can circulate to the brain and increase the risk of dementia. The cardiologists have known forever that high inflammation in the blood inflames and irritates the blood vessels of the heart, increase the risk of heart attack and stroke. The cancer doctors say high inflammation in the blood increase the risk of breast cancer and colon cancer. I measure inflammation because if my patient has high inflammation in the blood, then that inflamed blood will circulate to the eggs, inflame the eggs. They don't fertilize well. They make inflamed embryos that don't implant or miscarry. So if we have inflamed eggs, we get inflamed embryos. And if the blood circulates inflamed to the uterus and you put the perfect embryo into the uterus, an inflamed environment lowers the chance of pregnancy, increases the risk of miscarriage. 2 of the markers that I focus on are the highly sensitive C-reactive protein or CRP, and I measure glutathione in the blood as well. It's a great marker of inflammation. Another test that I do on my patients, test, is a swab, a Q-tip, a cotton swab in the cervix. Some doctors, IVF doctors, check for 2 or 3 microorganisms. I check for at least 9, because if there's an infection inside the cervix and you put an embryo catheter through the infected cervix to put the embryo into the uterus, it doesn't go well. So I do check that and treat it if need be. Most people have either a hysteroscopy to look directly into the uterus, or what I do is a saline infusion sonogram to make sure the inside of the uterus is good to hold the pregnancy. I had a patient this week who had failed IVF. Her saline sonogram was done in 2 dimensions, but the uterus is 3-dimensional. When I do it, we do 3D, 3-dimensional imaging of the inside of the uterus so as not to miss things that are in there that you can't see unless you do 3 dimensions. I do an endometrial biopsy for a special test called CD138, which looks for infection in the uterus. I have patients who've been instrumented in the uterus, procedure called dilatation and curettage, D&C, multiple prior intrauterine insemination, IUI, C-section, any kind of fibroid surgery, myomectomy, and if it's in the uterus, it can leave an infection in the uterus. If there's infection in the uterus, you put the perfect embryo in and it doesn't implant or it miscarries. I send my patients, my female patient blood to a special laboratory, one of the best in the country, to look at coagulation factors, because if the coagulation, the clotting factors are elevated, it can cut the blood flow to the uterus, and you put the embryo in, and if it doesn't get proper nutrients through blood flow, proper hormones, then the embryo may not implant. If pregnancy occurs, then if decreased blood flow can certainly cause the pregnancy to fail. I also measure natural killer cell activity. And if the killer cell activity is not normal, I treat it. If the coagulation factors are not normal, I treat it. I've seen too many patients who failed embryo transfer elsewhere, They're down to their last frozen embryo. I check they come to me desperate with the last embryo. I check their natural killer cells. It's not normal. I treat it. They implant their embryo. They go on and deliver a baby. So sperm and eggs have to be optimized before you start IVF. Like I said, I see patients who go to the doctor, IVF doctor, initial consultation, and they say in 3 weeks, you're going to get a period and we're going to start IVF. Fasten your seatbelt, cross your fingers, hope it goes well. And if it doesn't go well, we'll do it again. And if it doesn't do well, I see them right in the chart. Maybe the third time is the charm. Let's get it right the first time. I send all of my patients to fertility acupuncture. I'm a huge fan of fertility acupuncture. I strongly believe, and have for over 30 years, that it can increase the odds of IVF success. There are acupuncturists who do fertility, but they're not great at it. So I know who the excellent ones are, where I can refer my patients out to those true experts. When you do your IVF stimulation and you do the injectable fertility drugs to stimulate eggs to grow and mature and develop, it has to be individualized. It can't just be cookbook. Everybody gets the same drug, same dose, and see how it goes. It has to be individualized to you. When you're stimulating the eggs and the follicles to grow and mature and develop, you have to be monitored frequently, not, yeah, come in 5 days and we'll see how it's going. I typically monitor my stimulation patients every other day and towards the end, daily. I don't recommend fresh embryo transfer. If you want to DM me, feel free. I'm on Instagram and Facebook, and I can tell you why. But most excellent IVF centers don't do fresh embryo transfers. Get the eggs, get the sperm, grow the embryos, and 5 days later, put the embryo into a uterus. Most patients should not be doing fresh embryo transfer, if any, at all. I still get records. When I started 33 years ago, we grew embryos for 2 days in the laboratory, and then we put it into the uterus, and the success rate was 10%. And years later, we grew embryos for 3 days, and we put the embryos into the uterus, and we did a little bit better. I still see patients today who have been elsewhere where they had day 2 and day 3 transfers. No, 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 don't do it. We have to grow to day 5 to an advanced stage of development called blastocyst. Sometimes the embryo needs an extra day, day 6 to reach the blastocyst stage. We even grow embryos to day 7 if they need that extra day also. And then when we get them to day 5, day 6, day 7, advanced development called blastocyst, my patients have a microscopic piece removed from each embryo. It's called a biopsy. We send the cells to Progenesis for genetic analysis for random, spontaneous genetic mistakes like Down syndrome, and they check for many, 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 many of those genetic mistakes. I believe that if you don't genetically test your embryos and you put an embryo into a uterus, one of the biggest reasons it doesn't implant is because it looked, the embryo, amazing on the outside, but it was genetically not normal on the inside. If you implant the embryo, become pregnant, and lose the pregnancy, one of the biggest reasons could be that it was genetically not normal, and therefore, rather than deliver an abnormal baby, the body miscarries the pregnancy. So we love Progenesis. We biopsy our embryos and we send the cells to Progenesis for genetic analysis. And I think that's a critically important factor in the equation for success. So I'm different, as maybe you can tell from what I'm talking about, whether it's supplements or acupuncture or inflammation or cholesterol and triglycerides. I'm really kind of different. I am, like I said, 33 years in practice as a board certified expert, but I am at the cutting edge of reproductive medicine. I'm not doing what I was doing 6 months ago, let alone 6 years ago. I spend 90 minutes with new patient consultations. They're almost unheard of. My follow-up consultations are scheduled for 45 minutes. Whether we do them in person or virtually, they're long. It gives people personalized attention, individualized attention. All their questions are answered. I repeatedly ask at the end of the consult, do you have any further questions? Is there anything else that you need to ask me or discuss with me? People don't leave my consults or my office, oh, I didn't get to ask this and we didn't get to talk about that. So I spend a lot of time with my patients, educating them about what's going on and answering their questions. I also have IVF nurses, and I personally assign one of my IVF expert nurses to each patient. Here's her name, here's her phone extension, here's her email address, so that if you have a question that you want answered quickly, because I'm really busy, you can ask my nurse. So what you have to remember walking away from all of this is if you do all of the right things at the right place with the right fertility expert, then IVF success is usually within your reach. Thanks again for having me.
Thank you so much. That was a very informative discussion, a very informative presentation. Thank you so much. So let me start with a question from a patient. This patient has asked two questions. First one was, what AFC stands for? AFC.
AFC is antral follicle count. When a woman has her menstrual period, her body starts to grow and develop and mature multiple eggs. Normally, naturally, one of those eggs, which is inside a little house called a follicle, you can't see an egg without a microscope. So a woman on the ovary has these little fluid-filled structures, houses called follicles with the eggs inside of them. And when she comes to the office during her period, on the second or third or fourth day of her menstrual period, we do an ultrasound and we actually count and measure those follicles. And as I said earlier, the follicle count, it's called antral follicle count, or AFC for short. That count, we typically want to be between 10 and 20. If it's under 10, it's concerning. If it's over 20, it's actually often considered excessive. And some people say, oh yeah, the more eggs, the better. My follicle count is 40. Hooray, I got tons of eggs during my period, because that follicle count determines when we start the injectable fertility drugs for IVF, it gives us a pretty good sense of how many. So when we do IVF, we're doing it, we're feeding hormones, injectable fertility drugs, solely with the purpose of getting the ones that were destined to die that month, keep them around, grow them up, not allow them to die, and get them out of the body. So the antral follicle count is really important. If it's low, let's say it's 5, then it predicts we're not going to get very many eggs, if anything at all. If it's 40, you may say, hey, I won the lottery. But if you're sending your blood flow to too many eggs at the same time, you're branching your nutrients in all these different directions to feed and nourish 40 follicles instead of 20, then what happens is it ends up being sort of too many mouths to feed. And each one of those eggs becomes a little bit poorly nourished or malnourished, if that makes sense. So the antral follicle count, the AFC, is really important in what we do.
Thank you so much. Another question was, what if my doctor refuses to test extra things or do interpretation of blood tests, including testosterone or elevated DHEA, etc.?
Go elsewhere. You have a choice. You can, and I hear it all the time from patients who fail at these other IVF places. My doctor won't measure my natural killer cells. My doctor won't do this. My doctor refuses to use this treatment. So don't stay there. There are choices. There are other choices around. And like I said, sometimes it's a virtual consult. I do IVF. I have patients in Texas, in New York, in New Jersey, in Maryland. I see a lot of Maryland patients. There's actually a fertility acupuncture doctor in Maryland who sends a lot of her patients from Maryland down to see me or do virtual consults, and then they come down for their treatments. You have a choice. You don't have to stick with someone who won't listen.
Thank you so much. Another question from another patient asking if you could you please talk more about the reasons for not transferring embryo on day 3. I went to a new clinic and they said that this is what they do. They are willing to transfer an embryo on day 3.
So I'd love to answer the question. When pregnancy normally, naturally occurs in the body, normal pregnancy, the egg goes into the fallopian tube, not in vitro, natural pregnancy. The egg ovulates into the fallopian tube. The sperm fertilizes the egg in the fallopian tube. Once the egg fertilizes in the fallopian tube, the fertilized egg, the pregnancy, has to make its way through the fallopian tube. It takes about 3 days or so for that fertilized egg to make its way through the fallopian tube. So on day 3, a day 3 embryo is actually at a point naturally, normally, where it's in the fallopian tube getting ready to go into the uterus. So once it gets into the uterus, it floats around for 2 days, sometimes 3, looking for a place to grab on, and then it grabs on and someone's pregnant. So when pregnancy naturally occurs, it's a day 5 blastocyst that implants in the uterus. When you take a day 3 embryo, day 2, day 3 embryo, which is not at the normal stage of development where the embryo and the uterine lining have the proper crosstalk for implantation, when you take something that's not physiologic, that's not appropriate, a day 3 embryo that's normally still in the fallopian tube and hasn't even reached the uterus yet, and you put it in the uterus, it has a much lower chance of implanting and a much higher chance of miscarriage. So why would you do that? Some of the doctors argue, well, you do that because it's better off in the uterus than it is in the IVF laboratory. And many years ago, that might have been true. When we couldn't grow and nourish and sustain an embryo properly for 5 days in the laboratory, yeah, let's get it out of the lab and put it in a uterus. But when we have embryologists who are world-class embryologists who can grow and sustain an embryo for 5 days or 6 days and even 7 days in the laboratory until it reaches a proper stage of development where it's most likely to implant, why would you put a day 3 embryo into a uterus? It's not normal, it's not natural, it's not physiologic, and it dramatically lowers the chance of success.
Yeah, another extension.
And so some people argue, well, we don't want it to die in the laboratory. Let's get it into the uterus. And the fact is, in a good IVF, I'm sorry to interrupt, but I'm very passionate about this, as you can tell. If it doesn't make it in the laboratory to day 5, if it dies, the embryo dies, it would have died in the uterus.
Absolutely. So an extension to that same question was that the patient was saying that they had 3 embryos from a previous IVF treatment, and they were all abnormal. I did ask the patient her age. Hopefully she could tell us the age because that will give us some additional context. What is the likelihood? I can speak about euploidy at day 3 after you address this question, but what's your feeling about the euploid rate and day 3?
Were they blastocysts or were they day 3 embryos?
Day 3.
Nobody biopsies day 3 embryos anymore. Nobody. You don't genetically test day 3 embryos. The embryo on day 3 is usually between 8 and 10 cells in size. And when you biopsy a day 3 embryo and it's 8 cells, all you can do is take 1 cell off the embryo and genetically test it. You can't take 4 cells off because if it's an 8-cell embryo, you're removing half the embryo. You can't do that. So a day 3 embryo, which we used to do years and years and years and years ago, you take 1 cell off the embryo and you genetically test it. Where do we get that cell from? We get it from the outer edge of the embryo. And it's now known for years that embryos can have a mix of normal and genetically abnormal cells. And what the embryo does by day 3 is it tends to take the genetically abnormal cells and pushes them to the outside of the embryo. So when we biopsied day 3 embryos, when we took them from the outer edge, because that's the only place you can get it from, if it was that cell that was extruded, pushed to the outside because it was just an outlier, a bad cell, now you have an embryo that tests genetically not normal, you discard it, whereas all the other 7 cells in that embryo, day 3, could have been normal. Compare that to growing to day 5 blastocyst or day 6 blastocyst, where the embryo, the blastocyst, is now about 150, 200 cells. It's already determined whether that is genetically normal or not. The genetically abnormal cells, if there were a few, are long gone. And when we take cells from the outer part, 4 cells from the outer edge of that blastocyst, it should be representative of the entire blastocyst. But when you do it on day 3, we've learned years ago that that was not a smart thing to do. Does that answer the question?
Yeah, no, absolutely.
So embryos on day 3 push the abnormal cell to the outside. And if you have 3 of those and you biopsy 3 day 3 embryos, it's more likely to come back that it was an abnormal cell that you removed compared to normal. So we don't do that. We just don't do it.
Yeah. So just to add one more information to the patient question, because she clarified she is 39. She was 39 to 40. In that age group, the euploidy rate is about 30%. So on 3 embryos, if the stats follow that same patient, it would be maybe 1 normal out of 3.
Right.
But it's not usually, statistics don't follow small sample, but it's that typically a third of the embryos. The other thing that I would say as a geneticist is that embryos at day 3, when you biopsy them, you just take 1 cell, and that's not enough material to get an accurate result. So they tend to have more false positives than a blastocyst, where we analyze 5 to 10 cells, and that's kind of add a little bit to this. There is another question from another patient, Dr. Roseff. Tina is asking, what is your experience with egg quality? Can you help with egg quality, and especially in women's 40 years old and plus?
Great question. So women don't make new eggs. Women are born with eggs, and when you're 20 years old, the eggs are in your body for 20 years, and when you're 30, they're sitting on a shelf for 30 years, and when you're 40, they're sitting for 40 years. They accumulate garbage, junk, debris over time, toxins, anything you're exposed to it accumulates in the eggs. So I have women with bad eggs, and they're 32 years old. And when I do the treatments to try to improve the eggs in my 32-year-olds, it's way more likely to improve compared to the same test results in a 40-year-old or 41 or 42-year-old, because there's an age factor that we just cannot eliminate. So when I have my 40-year-old with what we call diminished ovarian reserve, low egg count or low egg quality, or both, we can do the treatments in the 40-year-old to try to improve them. It takes about 3 months, and then we retest. But I do tell them there's an age factor, and it may be worse 3 months later. It may be the same. It may be better. If you really want to try it, we'll do it. If it's a 30, 31, 32, 35, 37-year-old, different story. And it's more likely to be successful because of the age factor. You just can't eliminate that.
Thank you so much. One more question from Shannon. She is asking, do you have any data on IVF success among women of color, and specifically with fibroids, prevalence of fibroids?
Well, fibroids, benign muscle growths of the uterus, are relatively common. About 40% of women aged 40 have fibroids, but genetically, they seem to be more common in women of color, in African American women, compared to other ethnic backgrounds. As far as, I think your question was, do I have IVF success broken down into African American versus other success? And I don't. I don't have that data. If it's just skin color, I have women of all ethnic backgrounds who come to see me, and my success rate, while I haven't broken it down into ethnicity, seems to be the same in no matter what the whatever the skin color is. Now, fibroids, whether the woman is of color or lighter skin or whatever the skin color is or ethnic background, fibroids sometimes are not a problem. The saying that I have is, if it ain't broke, don't try to fix it. Some people come and they say, oh, I have a fibroid, I need surgery. And when I investigate it, I say, you know, it's there, but just because it's there doesn't mean you need an operation. So it depends on how big the fibroids are. It depends on certainly their location. It depends on how many there are. So it's not a simple answer. Oh, there's a fibroid, you need to do this, you need to do that. It depends on the size, the number, and the location of the fibroids. Are they impinging upon, are they compressing the cavity inside the uterus where the pregnancy needs to grow? Are they just simply sitting on the outside of the uterus? You can have a massive fibroid on the outside of the uterus, and it's not usually a problem. If it's pushing in to where the uterine cavity is, where the pregnancy grows, that could be a problem. If it's growing inside the uterus, that's a problem if it's in the way of pregnancy success. So there's no simple answer to the question. It has to be looked at with each woman individually.
Thank you so much. I think we have addressed some of the questions that were addressed today. We have one more question from Oksana. She's asking, please share your opinion about PRP, ovarian rejuvenation, and zone therapy.
PRP, there's nobody in the world has a lot of experience with, so PRP is platelet-rich plasma. Platelet-rich plasma is used in certain medical fields where the patient's blood is collected, the patient's blood is processed through a particular device, or at least it should be in a specific device that isolates what's called plasma rich in platelets, and the PRP is then in the orthopedic field, for example, injected into the knee joint to help to bring better blood flow to the area and perhaps heal the area. I went for oral surgery, and my oral surgeon collected my blood, processed it, and injected platelet-rich plasma into my mouth where I was going to have my dental work done. There are different disciplines using platelet-rich plasma PRP. There are some doctors around the world who are under ultrasound guidance. They're putting egg retrieval needles through the vagina into the ovary to inject PRP, platelet-rich plasma, with the hope that it will rejuvenate bad eggs, older eggs, so that women who have really big egg problems, or older women, 46, 47, 50-year-old women, can rejuvenate their ovaries and perhaps ovulate and conceive. Nobody in the world has a lot of data about it. There are entrepreneurs who publish. You can publish anything you want, papers suggesting success. Yeah, we did it in 3 patients. 2 of them got pregnant. Well, maybe they would have gotten pregnant had you done nothing with them anyway. So the studies are small. Some people are advertising it. I saw one patient who came to me from New York, her doctor in New York, her fertility doctor, the lady's FSH was high, her AMH was low. Basically, she had big egg problems. She was 41 years old. Her doctor injected PRP. Her FSH came down the next month. Her AMH went up the next month. And the month after that, her FSH was back to where it had started. Her AMH was back to where it started. And so she had a temporary mild effect for a month. And then the month after that, nothing. So I'm not a fan of PRP injection. There is risk to it for sure. What was the second part of the question? Was it ozone therapy? I don't hear you, you're muted.
So for the PRP, she was asking if it improves egg quality. That was one of the questions.
Well, that's the theory behind what it's supposed to do. Do I think that it's ready for prime time? Do I think, no, it's experimental, it's risky, and the limited experience I've had with it is it really does virtually little to nothing.
And the second piece was about the ozone therapy.
I have no experience. I've read papers. There is a local practice doing ozone therapy in South Florida. I've read published papers on it, and I am not impressed at all.
Very good. Well, Dr. Roseff, thank you so much for your for addressing all the questions.
My pleasure.
I appreciate your time that you took to talk to us about IVF optimizations and all the factors that really matter. Thank you so much. If you would like to give us some closing, maybe some general recommendation, or if you want to talk about anything of interest before we wrap up the webinar.
Well, again, a lot of what I do is in vitro fertilization, although I do also focus on trying natural therapies, simpler therapies for natural conception. If it might be if somebody has no fallopian tubes, they need IVF. If the sperm is horrible, they probably need IVF. But just because your doctor says you need IVF, you may want to get a second opinion on it. For whatever it's worth, my practice, IVF MD, offers free second opinions. Whether it's, do I need to do another IVF? Should I do another IVF? Do I need IVF? We offer that. But like I said during my talk, if you're going to do IVF, always take a half a step back and let the doctor, or the doctor should, dot a whole bunch of I's, cross a whole bunch of T's before you do IVF to optimize the outcome so that when you do IVF, it's most likely going to be successful right out the gate. There are risks to IVF, and there is some buzz out there about repeated IVF, possibly increasing the risk of ovarian cancer. It's out there. And I had a patient recently in upstate New York who consulted with me. She failed 7 IVF cycles. She said, I want you to do number 8. And I told her, no, I'm not doing number 8 because it's a risk to your health, and your health is the most important thing that you have. So it wasn't to punish her or upset her or hurt her. It's because if you went through 7, I'm not doing number 8. So do it once, do it right, make it work. If anybody wants to direct message me, again, I'm on Facebook and Instagram. You can just look up my name. I also go as the baby maker. A lot of people call me the baby maker. And you can find me that way, sometimes on social media. I'm in Boca Raton, Florida. I am in an IVF practice that's renowned for IVF success. There are different doctors in my practice. Everybody brings something different to the table. So it's not like every doctor is the same. It's just like any practice. And that's really it. Just, do it right the first time. Don't wait for failure. Proactively, prospectively look at what should be done, or have your doctor look at what they need to know, so that when you move forward, it's going to be the absolute best it can be. You don't want to look back after IVF and say, why didn't we do this? We could have done this. We should have done that. I wish we did this. That's not the way to do it. Do it proactively, prospectively, make it work.
Awesome. And one of the patient was asking about your contact, how she would be able to contact you. And I would say you can either provide her with a contact, or we can provide her with the contact privately.
My group's website is ivfmd.com. When you go to our homepage, it has all the doctors listed. You can click on my picture or my bio, and tells you a little bit about my background. I was the founder and director of the reproductive medicine division at a large medical center in New Jersey 33 years ago. I was recruited to go do that, and I practiced in New Jersey for 17 years. I was recruited to come to South Florida. So you'll see all about that in my bio if you want. If you want, I can tell you the phone number and the direct extension of my office if you want to call. It's 561-549-9010. When you call that number, you hear a recording. Thank you for calling IVF MD. You just have to press 3340. 3340 is the direct extension to my office in Boca Raton, and somebody can help you.
So that was 561-549-9010, extension 3340. Correct?
Yes.
Awesome. Very good. Well, thank you so much again. I can't thank you enough for the time you took to explain how you manage your IVF treatment and the optimization aspect. Thank you so much.
It's a pleasure. Thank you for having me.
And I will see you very soon. Thanks a lot.